Welcome to the Cardio Endo Suite, where dentistry meets cardiology and nobody is quite sure whether to pick up a mirror or a stethoscope. Our patient today has a history of cardiovascular disease and needs endodontic treatment. They sit in the dental chair wearing a dental bib and cardiac leads, the EKG monitor beeping steadily beside them. An endodontic tray is positioned right next to a bright red defibrillator. Captain Kaplan stands at the entrance in full naval regalia, panoramic X-ray tucked under his arm like a military baton. This is the setting where we will learn everything you need to know about cardiovascular disease and endodontics.
Look to the left. Captain Kaplan, our landmark author, has made a discovery. He pins his panoramic radiograph to the wall right next to the EKG monitor. See that dark periapical shadow at the root tip? From that lesion, tiny cartoon bacteria stream upward in a dotted line toward the heart on the monitor, which flickers anxiously. Kaplan's research demonstrated an association between periapical pathology and cardiovascular disease. The inflammatory mediators and bacteremia originating from periapical infections can contribute to systemic atherosclerotic and cardiovascular risk. Treating that periapical infection is not just about the tooth, it may carry cardiovascular benefit. Remember Kaplan, the captain at the root of the heart problem.
Now Jankit arrives, and you cannot miss that jacket. He unrolls a massive meta-analysis scroll across the floor of the Cardio Endo Suite, showing a chain of oral bacteria linked by arrows to an inflamed cartoon heart. Jankit's landmark meta-analysis consolidated evidence from multiple studies, reinforcing that oral and periapical infections are associated with an increased risk of cardiovascular events. The bacteria and their inflammatory byproducts enter systemic circulation, promote endothelial dysfunction, and accelerate atherosclerosis. Captain Kaplan nods vigorously from the corner. The data all points the same direction. Know both names for the board exam, Kaplan and Jankit. Treating periapical disease is not just dentistry, it is potentially preventive cardiology.
The AHA rep strides in wearing her red blazer and sets up a velvet rope divider. She is here to sort out infective endocarditis prophylaxis, and she does not mess around. Only specific high-risk conditions require antibiotic coverage before endodontic procedures. Prosthetic heart valves, a history of prior infective endocarditis, specific congenital heart diseases, and cardiac transplant recipients with valve pathology. These patients get the VIP treatment, 2 grams of amoxicillin orally, 30 to 60 minutes before the procedure. Penicillin allergic. The AHA rep has a backup card, clindamycin 300 milligrams. Now notice the other line, turned away at the velvet rope. Coronary artery disease, coronary stents, CABG patients, pacemakers, and mitral valve prolapse without regurgitation do not require prophylaxis. Many residents get this wrong. Commit the high-risk list to memory.
While our careful pharmacist, scale perfectly balanced on his head, brings us the epinephrine question, which trips up many residents. Here is the rule. Vasoconstrictors are not absolutely contraindicated in cardiac patients. 2 cartridges of 1 to 100,000 epinephrine, totaling 0.04 milligrams, is the safe limit per AHA and ADA guidelines for patients with controlled cardiovascular disease. Wall's scale tips perfectly at that mark and glows green. But look at the boxing ring to his left. When a patient takes a non-selective beta blocker like propranolol, epinephrine can cause a hypertensive crisis through unopposed alpha receptor stimulation. The beta receptor is blocked, so all the epi goes to alpha and the blood pressure gauge blows into the red. Non-selective beta blockers limit or avoid epinephrine. Cardioselective beta blockers like metoprolol carry lower risk. Controlled hypertension, stable angina, coronary artery disease without non-selective beta blockers. 2 cartridges, guideline approved.
Onto the anticoagulant checkpoint, and this is critical for board exams. Do not routinely discontinue anticoagulants for endodontic procedures. Warfarin patients with an INR under 3.5 can safely receive endo treatment. The meter on the booth glows green at 2.8. NOACs, apixaban, rivaroxaban, and others can also continue without dose adjustment for routine endo procedures. For aspirin, the answer is almost universally, do not stop it. See that rebound monster lurking behind the bush? That is the platelet hyperactivation rebound that occurs when aspirin is abruptly discontinued. It can precipitate a cardiovascular event far more dangerous than any procedural bleeding. Manage hemostasis locally, gauze, pressure, hemostatic agents. The anticoagulants stay. The checkpoint gate stays open.
Finally, what happens if angina strikes mid-treatment? Stop everything immediately. The dentist holds nitroglycerin ready for sublingual placement. Watch the 5-minute clock on the wall. If the pain resolves within 5 minutes, you may continue cautiously. If it does not resolve within 5 minutes, call 911. This may be a myocardial infarction. Notice the morning sun shining through the window. Cardiac patients should be scheduled in the morning when they are most rested and physiologically stable. Keep appointments short to minimize physical and psychological stress. Manage anxiety proactively. Stress reduction is a clinical intervention, not just a suggestion. And as Wall and Kaplan peek in from the doorway with concerned faces, remember, when you leave this room, you are equipped. Know who needs IE prophylaxis. Know how much epinephrine is safe and when it is not. Know to keep anticoagulants running. Know how to manage an anginal episode. And remember that the periapical infection you treat may matter to the heart.